Good afternoon. Sorry for the slight delay. My name's Greg Dorr, and I'll be chairing the first part of the seminar today and giving the welcome. So firstly, I'd like to acknowledge the traditional custodians of the lands that we're on today, the Bidjigal people, the Eora Nation, and extend my respect to elders past and present, and also to acknowledge Aboriginal and Torres Strait Islander members that are attending today, either here or online. So the format of today's seminar will be, we'll have two presentations from PhD students, one from our program, the Viral Hepatitis Clinical Research Program, and one from Raina McIntyre's program. So firstly, I'd like to just do a bit of housekeeping. So in terms of questioning those online, just pop your questions in the Q&A, and we'll have questions after the 20-minute presentations. There'll be a roving mic for those who want to ask questions here. So look, it's a great pleasure to introduce Hassan. Syed Hassan Bin Usman Shah is a PhD student in our program who came to us about 4 years ago on a PhD Scientia fellowship. And Hassan's had a background as a medical doctor and public health researcher for more than 10 years in several countries, most recently in Qatar before coming to Australia. He's back in Pakistan working now, but he's completed his PhD and submitted recently. So it's been wonderful to have Hassan as part of the program over the last sort of 4 years. So I'm really looking forward to his presentation. So take it away, Hassan.
Thank you for the introduction, Greg. So my name is Hassan. I'm a PhD student at the Viral Hepatitis Clinical Research Program. Today, I'm going to present the findings of my PhD project, which is evaluation of hepatitis B cascade of care and the disease burden in New South Wales, Australia. It is supervised by Professor Greg Dorr and his team. These are my funding sources and disclosures. I would like to acknowledge the traditional custodians of the land on which we gather today and pay my respect to the past, present, and elders, past, present. Today, we are presenting from the Bidjigal people of the Eora Nation. I extend that respect to the Aboriginal and Torres Strait Islander people joining us today here in the audience and online. I would also like to grab this opportunity to once again thank all my supervisors for all the efforts they have done throughout the 4 years. Just a brief background. In 2020, an estimated of around 200,000 people were living with hepatitis, chronic hepatitis B, which represents around 1% of the total population in Australia. Enhanced hepatitis B diagnosis and timely linkage to care and treatment uptake is required to achieve the 2030 WHO elimination targets. Unfortunately, in many countries, including Australia, hepatitis B diagnosis and treatment remains suboptimal. Characterization of hepatitis B virus care cascade, decompensated cirrhosis, hepatocellular carcinoma, and liver mortality is crucial for monitoring hepatitis B elimination process. So keeping this in mind, we aim to assess the trends in hepatitis B-related DC and HCC diagnosis, including late hepatitis notifications, and viral liver-related mortality. Then we also did the concordance in the records of liver-related mortality among people with hepatitis B and hepatitis C notifications. We also assessed hepatitis B care cascade, including timely HBV DNA testing. And finally, the fourth aim was to assess the survival rates following hepatitis B-related HCC diagnosis among the people living in New South Wales with hepatitis B notification. So to do this, we had different administrative data sets and we linked them together. So starting from the notifications, which started from 1993 to 2017, we linked the notifications to hospital admissions, hepatitis B DNA testing and treatment data, which was from the PBS and MPS data sets, all-cause mortalities, and the cancer registries are the main data sets that we used. So today I'll just discuss, try to cover the three main aims because of the shortage of the time. So the primary study outcome were the hepatitis B related DC and HCC diagnosis, including late HPV notification and liver-related mortality. Late hepatitis B notification was defined as a notification at or within 2 years of HCC or DC diagnosis. The second aim was to see ever received HPV DNA testing, and ever received DNA testing was defined as HPV DNA testing recorded in the MBS dataset and evaluated among all people with HPV notification. Timely HPV DNA testing was within 4 weeks of HPV notification. We also assessed the treatment uptake, and the HPV treatment initiation was defined as at least one HPV treatment prescription dispensed, which was recorded in the PBS dataset and evaluated among all people with HPV notification. And finally, we also assessed the survival following HPV related hepatocellular carcinoma. So for the first aim, we assessed the temporal trends in hepatitis B related DC and HCC and liver related mortality. We calculated the numbers and age standardized incidence rates. Unadjusted and adjusted Cox proportional hazard regression analysis was performed. In all time to event analysis, time at risk started on HPV notification, ended on the date of DC or HCC diagnosis, death, or the last follow-up, whichever occurred first. Following unadjusted analysis, multivariable logistic regression analysis evaluated the factors associated with late HPV notification. For the third aim, the time to HPV DNA testing and treatment initiation was evaluated. Kaplan-Meier cumulative curves were used to estimate the cumulative probability for testing and treatment initiation, and unadjusted and adjusted multivariate Cox proportional hazard regression analysis was used to evaluate the factors associated both with testing and treatment initiation. And for the last aim, it was the survival. So we did the Kaplan-Meier survival curves. Unadjusted and adjusted Cox regression was used to evaluate the factors associated with survival. For each outcome, the covariates included age, sex, country of birth, ethnicity, alcohol use disorder, DC and HCC status, co-infections with HCV and HIV, distance from the health facility, and the time of notification. So coming on the results, so we had total of 60,660 people. Out of those, we had around 2% each for DC and HCC diagnosis, and around 1,200 deaths, which were related to liver related deaths. The majority of the people were male, and the most common co-infection was HCV, and alcohol use disorder was more common in the people with DC diagnosis. So since the early 2000s, the number of DC and HCC diagnoses increased. However, on the right-hand side, you can see that the age standardized incidence rate decreased from around 2.6 to around 1.9 from 2003 to 2017. Similarly, the liver-related mortality also decreased. The age standardized incidence rate of liver-related mortality also decreased from around 2.6, and it decreased to around 1.14. Overall, among 1,276 people with DC diagnosis, around 33% had a late HPV notification. It declined from 41% in 2001 to 2009 to around 29% in 2010 to 18. Compared to people with an HPV monoinfection, those with HCV co-infection had a slightly larger decline in the proportion with late HPV notification. Similarly, among people with HCC diagnosis, Around 31% had a late HPV notification, which declined from 40% to 25% in 2010 and 18. And people with HCV co-infection, the proportion of late notification declined from 40 to 37%. In adjusted analysis, DC diagnosis was associated with older age, history of alcohol use disorder, male sex, and HCV co-infection, and Charlson's comorbidity index score of 1 or more, and it was very high for the 3+ score. In adjusted analysis for HCC diagnosis, it was associated again with older age, male sex, country of birth outside Australia, HCV co-infection, and Charlson comorbidity score of 1 and more than that. So the takeaway messages from this first aim were: in an era of improved antiviral hepatitis treatment, the risk of hepatitis B-related liver mortality and morbidity has declined. HCV co-infection and alcohol use disorder are the modifiable risk factors. Further strategies to reduce HPV burden include enhanced HPV screening and early diagnosis, increased HPV treatment coverage for eligible individuals, and addressing modifiable cofactors such as HCV co-infection and alcohol use disorder. So the second aim was to assess the people with the testing and treatment. And we had a cohort of around 15,200 individuals. It was from 2010 to 2018. Again, the males were predominant in this cohort also. Most of the people were from East Asia. 3% of Aboriginal and Torres Strait Islanders and had a history of alcohol use disorder, and 1% each of HIV co-infection and HCC diagnosis. HCV co-infection was around 5% in this cohort. So among 15,000 people with HPV notification, around 10,479, which was around 69%, they were tested for HPV DNA. A total of 21%, which is around 3,179, they initiated hepatitis B treatment. Among all individuals tested for hepatitis B, around 50% had timely HPV DNA testing. So among those who were treated, which is around 3,000, the proportion of individuals initiated on the treatment by a gastroenterologist declined from 65% to 59% in 2014 to 18, which we called the later period. But encouragingly, the proportion of GP prescribed HPV treatment initiation increased to around 26%. At the end of 28 days following HPV notification, the cumulative probability of HPV DNA testing was higher among those who were notified during 2014 and 17 compared to those notified during 2010 and 13. Similarly, the cumulative probability of HPV treatment, again, it was higher among the people who were notified during 2014 to 2017. Now, the factors associated with HPV DNA testing. In adjusted analysis, the rate of HPV DNA testing was higher among people aged more than 45 compared to those less than 29 years. HPV DNA testing was more likely among those born overseas with HIV co-infection, HCC, and the later period. HPV DNA testing was less likely among females and among those with a history of alcohol use disorder. For the treatment initiation, in the adjusted analysis, the rate of HPV treatment initiation was higher among people aged more than 45. Similarly, the treatment initiation was more among those born overseas, among those with a history of TC diagnosis and HCC diagnosis, HIV co-infection, and the later period, which is 2014 to 2017. However, the treatment initiation was less likely among females and Aboriginal and Torres Strait Islander people. So the takeaway messages from this chapter were, our study demonstrates major gaps in cascade of care for people living with chronic hepatitis B, despite government funding, testing, and antiviral treatment. HPV DNA testing and treatment uptake improved over time. Despite this improvement, we have identified some key population groups like the females and the Aboriginal and Torres Strait Islander people in need of increased intervention to enhance testing and treatment and further progress towards elimination. The encouraging point was the proportion of GP prescribed HPV treatment initiation increased in the later period. Now, coming on to my last chapter, which was survival following the HCC diagnosis. The survival improved during the later period, which is visible in the blue line. It was like around 1.4. The median survival was around 1.4 in 2001, during 2001 to 6. And after the availability of the treatment, it suddenly increased. Between 2001 and 2018, the overall median survival was around 1.6 years. The median survival increased from 1.4 to 2.4 years among those with HCC diagnosis. The survival probability at 1 and 2 years among those diagnosed in 2015 and 18, which was around 61 and 53%, is improved compared to 2001 and 6. The factors associated with mortality, in the adjusted Cox regression analysis, the factors associated with reduced mortality following HCC diagnosis were HPV treatment initiation and receipt of the curative procedures. However, the history of decompensated cirrhosis and Charlson's comorbidity index of score 3+ were associated with increased mortality. So the takeaway messages from this chapter were, our study demonstrated a significant improvement of hepatitis B related HCC survival in 2007 to 2010, but then there was a plateau, which is concerning. Additional research encompassing the recent period of availability to more effective systematic therapies will be essential to further explore the trends in HCC survival. Key areas for concerted efforts are earlier HPV diagnosis, enhanced HPV treatment coverage, and enhanced HCC screening to enable earlier diagnosis and greater access to potentially curative procedures. In conclusion, enhanced hepatitis B cascade of care, particularly higher coverage of more effective antiviral therapy, has produced individual as well as population level benefits. Nonetheless, HPV testing and treatment uptake is in most countries is suboptimal, including Australia, which has the potential to impact HPV elimination goals. Our results have highlighted the urgent need for innovative public health action and improved surveillance system to monitor barriers and equalize HPV elimination process, particularly among some key population groups. Targeted strategies are required to further reduce late HPV diagnosis and increase HPV treatment coverage to minimize HPV disease burden and improve the health and well-being of people living with hepatitis B. Higher level of HCC screening to enable earlier diagnosis and greater access to potentially curative procedures. Together with improved HCC management, are required to further reduce liver disease morbidity and mortality. I thank you all. If you have any questions.
Thanks very much, Hassan, for a really clear presentation, and thanks for getting up fairly early in Pakistan. Any questions in the room? And I'll just have a look on the Q&A to see if there's online questions as well. There's one online question from Virginia. Hassan, that was great. Could you explain a bit more about the improved strategies for testing and treatment that you listed in your takeaway messages?
Yeah, so we are planning to include everyone, especially the people with linguistic barrier and far-flung areas. So outreach workers, the local community health workers, if they can go in the community, like for example, the Aboriginal and Torres Strait Islander people who live in the far-flung areas, so it will be a better opportunity for them to engage them and to increase the uptake for the hepatitis B DNA testing as well as the treatment. Similarly, if we have people with different backgrounds, cultural and linguistic backgrounds, and if we hire the healthcare workers who are from those communities, that would be a better option. So these are few options, and other options are written in my thesis, which I'll explain it later.
I should just add, Hassan, I think one of the points that you made about the increasing proportion of treatment through nurse practitioners and general practitioners is a really key aspect of trying to broaden the sort of practitioner base. We've done that obviously in HIV, we've done that very well in hepatitis C, and we're trying to sort of use that as a platform to enhance linkage to care and treatment.
Yeah, definitely.
If there's no more questions, I'd really like to thank Hassan. It's been wonderful having you with our program for 4 years, Hassan. Real pleasure to supervise you, and all the best for the future. Thanks again.
Thank you very much. Bye.
And I'll just hand over to Raina McIntyre to chair the next session for her presentation from one of her PhD students, Haley.
Okay, so I'd also like to acknowledge the traditional owners of the land and pay my respects to elders past and present, and any Aboriginal or Torres Strait Islander people here today, online or in the room. And it's a great pleasure to introduce Haley Stone, who's one of our PhD students. This is sort of partway through her 3rd year of her PhD, and she'll be submitting next year. And she's done an enormous amount of work on methodologies for modeling of epidemic infectious diseases. So, Haley.
Hi again. Before I begin, I would also like to pay my respects and acknowledge the Bidjigal people, who are the traditional custodians of the land on which this meeting takes place, and acknowledge their elders, both past and present, and extend that respect to other Aboriginal, Torres Strait Islander people who are present here today or online. The title of my thesis is Epidemic Modeling Techniques for Pandemic Preparedness. My supervisors are Raina McIntyre, David Heslop, and Matthew Scott from Arizona State. So just an outline of what I'm going to be talking about. I'm going to give an outline of my thesis, of what I did in my research, and then I will talk about influenza A H5N1 and a phylogenetic analysis background, and then I will talk about one of my chapters that I'm currently working on and finishing up, and an impact overall of my research. So just to go into the overall overview of my thesis. So this thesis began in 2021. Many countries had started rolling out COVID-19 vaccine campaigns. In addition, different variants of SARS-CoV-2 virus were identified in various countries. A lot was not really understood, but even the stuff that we did understand did change as different variants arose. Epidemic modeling provides insights into viruses' impact on both a host population and pathogen levels. During the early stage of the pandemic, when the understanding of full protection transmission profiles were still incomplete, models would focus on Rapid outputs for broad populations to provide timely insights. As more is understood, we would focus on individual settings, which gives a greater understanding of spatial and temporal dynamics, as well as transmission in those settings. In addition, throughout this entire process, a virus will continually have mutations. Comprehending those changes and how that impacts transmission is incredibly important for policy. Combining these model types provides a comprehensive view of infectious disease dynamics and enables a more effective and targeted public health interventions. So an overview of what my thesis includes. It includes 2 respiratory diseases of pandemic potential, SARS-CoV-2 and influenza A H5N1. I also focus on 3 different model types: the susceptible, exposed, infected, recovered model, agent-based models, and phylogenetic models. Each model provides a different perspective on the transmission dynamics of infectious diseases. SERs capture compartmentalized population dynamics, and I've written 2 on those. And then agent-based models simulate individual interactions. I'm currently finishing up one now on contact matrix and aged care facilities. And then phylogenetic models explore evolutionary understanding and how they work with relationships to epidemiology. Integrating these perspectives provides a more holistic understanding. The rest of this talk will focus on one of my chapters, which is on avian influenza and phylogenetic models. So just a background into both. Avian influenza viruses belong to Orthomyxoviridae family of the single-stranded envelope RNA viruses. They have 8 segments. Ooh, cool. They have 8 segments, 2 of which are the hemagglutinin and neuraminidase, which makes the H5 and the N1. There are 2 types based off of the severity and pathogenicity in poultry. H5N1 is a highly pathogenic avian influenza. The first case of H5N1 was detected in a farmed goose in 1996 in Guangdong, China. And the first human case was in 1997 within Hong Kong. The current clade, which is quite topical at the moment, is H5N1 2.3.4.4b. I know that's a mouthful. It was first detected in 2020 and has since had intercontinental spread. So what is required for a pandemic strain to emerge? First of all, sialic acid receptors are an entryway for multiple animal and human diseases, including coronaviruses. Human influenzas preferably bind to alpha-2/6, and avians influenzas preferably bind to alpha-2/3. Except for a few exceptions, the HA receptor binding site sequence in H5N1 retains the avian preference for sialic acid to alpha-2/3 receptors. In humans, the alpha-2/6 are predominant in upper respiratory system, which means that sustained respiratory outbreaks will need the switch for it to occur. And then in addition, there's a thing called mammalian adaptations, which you see in the news quite often. Those are adaptations that make it so you can transmit between mammals readily. And those are typically found in the PB2 segment. And some of the ones that are listed here are the most common that we look out for. The top 2 being the ones that we've seen the most with the 2.3.4.4b. I will try to limit the amount of times I say that because I will stutter over it. So a background into phylogenetic models. I am not going to go in very big detail. I'm just going to give a little background just to kind of make sure we all are on the same page. Phylogenetic analysis are a method of understanding taxonomic classifications based on their evolutionary history. So there are 2 analyses or 2 components to those analyses. There's phylogeny inference, which is the inference of branching orders and ultimately the evolutionary relationships between taxa. Taxa includes entities such as genes, populations, and species. And then there's character and rate analysis, which uses phylogeny as an analytical framework for rigorous understanding of the evolution. So So you have your ancestral root is the one in brown, and that's what the furthest ancestor that you could possibly derive from the lineages that you have. Then you have your branches that connect the nodes, which are for inside. Those are your common ancestors. They're the ones closest to the lineages that you've submitted. And then you have your external nodes, which are usually the lineages that you submit into a phylogenetic tree. So 2 seconds. Phylogenetic tree building are mathematical and or statistical methods for inferring the divergence order of taxa, as well as the lengths of branches that connect them. There are 2 types of data for phylogenetic inferences, and that's character-based methods and distance-based methods. This is just to show different ways that you try to assume what type of phylogenetic tree you're going to use, but for ours, we're using the maximum likelihood. So to delve into my chapter, just a bit of background. There have been 909 human cases of H5N1 globally across 23 countries. That is a timeline by year. I was not about to do month. By year, there's been 909 with a particular spike in Egypt. But however, the bird cases since 2021 have also been increasing, which just shows that we need to continually research this kind of work, especially with the new strain that seems to be infecting different mammal species in addition to human species. So one of the reasons for doing this research as well is detail on the cases are usually through reports and not through their sequence metadata. So when you grab a sequence online that has a metadata that's associated with it that has certain details about the case. So they don't have that usually. This study seeks to address this gap by creating a comprehensive epidemiological data set and associate it with sequences. So that starts with matching the 2 data sets. So what you'd see on the right is 2 different data sets that we have. So we had collected previously, before I started even, case details, which includes all that you can see on the left, in addition to the things on the right. And then gene bank GSA metadata includes stuff that you can see on the left and the one on the bottom. You might notice that there is more than 909 on the epi data set, and there's less on the metadata and the metadata for gene bank and GSA. Oftentimes, a lab will submit multiple sequences for a human case, and oftentimes there'll be multiple reports, especially if you're doing a retrospective analysis. There'll be multiple times that we would think that these are separate cases, even if they're not, especially when there is a ton going on in Egypt. Like you saw, there was a lot of reports all at once. So I created a matching algorithm, which has exact matching, which if you saw before, there are isolate identification numbers that both the 2 data sets had. So that's just an easy one. If they're exactly the same, easy, matched, put to the side. Next was probabilistic matching, which is pretty much what everything else was. It used basically a threshold limit for a certain amount. So there's points on how much a match would add up. And if they hit within a certain range for that category, they end up being very high, high, medium, or low. We also had fuzzy matching. So some of, as you can see here, there's location beyond country. So if we had the ability to see more granular location, then we tried to match those using fuzzy matching. So very high, had to have all 5. So that's country, date, age, sex, and fuzzy location. Didn't happen. High would have been date, country, and fuzzy location with one of age or sex, or year and country, which meant 1 case per country per year. So if there's a case that's in Bangladesh and it's only one that year, then that one would be put in very high. Then there's medium, which is country and date, and then 1 of age or sex. And then low is just only country and date. So that are big numbers of 652,178, but that's all the matches that could potentially happen. That's just multiplying 658 by 991. There were 89 that were exact matched, and 96 that were high. And like I said before, there was 100, if you could add up 89 and 96, that's 185. So there's 148 sequences that we had after we removed the double sequences, aka multiple cases of the same thing. We then matched these strains. We used those matched strains to phylogenetically analyze by two traits, which was patient outcome, because if you saw here before, patient status for the metadata was only reported in 6.56 of the patients. So understanding whether or not a patient survived or died at the end might be something worthwhile in looking at. And also by epi risk, which is just basically their occupation, what exposed them, and what could have potentially had different outcomes to the person in the case. So this is very zoomed out. That's only because I'm trying to put it on a page for you. So there are mortality clusters. The easiest way to find them is that their ancestral nodes or their internal nodes are also mortality. So you can see them here. The first one is clade 1 across Cambodia, Vietnam, and Thailand. The second one is in Indonesia exclusively, which is quite interesting. Most of the other clades have multiple countries involved in it, but this clade stayed exclusively within Indonesia, and that is 2.1.3.2b. Long names. And then just to pay attention to the current one. So if you've heard about the cases in Cambodia and the recent one in Vietnam, those fall within this cluster, and they have all had a high mortality rate. And that's 2.3.2.1c. Just to talk about the new strain, 2.3.4.4b. A lot of the cases that you see in blue, which would mean survived, were identified through common surveillance of farms that had poultry outbreaks. So they weren't even symptomatic when they were being tested. So that's most likely why we saw them versus like other countries such as Ecuador and Chile. They were identified once they went to the hospital. Then you have exposure rate. So we used an algorithm proposed by another paper to categorize all exposure information, either 0, low, medium, or high. And if there's no information whatsoever on this person, the category is then put as unknown. Occupation is directly in contact with poultry, so therefore it was high. High exposure risk clusters were found, as we just talked about, in the United Kingdom and Spain. They had direct contact with poultry at the time and were involved in culling of those farms. And then the other one, which was actually from a mortality cluster from before, is clade 1 in Vietnam and Thailand, and 1 in Cambodia. Just to point out that the Cambodian strain as well also had a medium scale, which meant that they were in contact with backyard poultry. Almost all of these strains had over 200 birds that were associated in that area. So almost all of them were medium, sorry. So the conclusion of this is that the creation of curated epidemiological data sets coupled with phylogenetic analysis has allowed us to identify key clusters that might not be visualized before and patterns of H5N1 transmission across various regions. This concept extends beyond H5N1 and holds potential application for other diseases of interest. Future research should explore how viral evolution impacts clinical signs and severity of patients as well. That's whether or not they went to the hospital or not. Examine of other segments of virus should also be looked at because we talked about that PB2 earlier. Just looking into what mammalian adaptations might be impacting on these as well. So impact overall of my thesis. I did end up studying 2 highly unstable RNA viruses with pandemic potential and significant public health repercussions. A paper or a conversation piece that we just put out makes H5N1 remember that it's quite relevant right now. Said in cows in the US, and a person in the US has also tested positive. And then exploring diverse methodologies in epidemic modeling has significantly enhanced our understanding and my understanding of the intricacies behind transmission dynamics and evolutionary processes. Again, I would like to thank my supervisors for their constant support and guidance during this entire process, to the co-authors of other papers, and to the biosecurity program, who most of them are here right now. Thank you.
Thanks, Haley. Any questions for Haley in the room? And if you've got questions online, you can put them in the Q&A.
Thanks, Haley. Great presentation. The bird flu cases, is there sentinel surveillance for detection? How are those cases picked up? I mean, how standard is the sort of surveillance over time that might potentially influence those sort of rates as a sort of early warning system for spread to humans?
So currently, I would say it's better than it was before, but it's also reached countries that have higher sentinel surveillance, like European countries that have a bit more set up. Prior to this, it was in some of the Asian countries where it was quite prominent with other clades as well, where it might be more difficult to identify, especially when it gets to backyard poultry. Like you could do sentinel surveillance on poultry, which is what some countries do, but when it extends to backyard poultry, it's quite hard to identify when those cases in birds are there. So then the human cases are usually presenting when they make it to the hospital, not when they're feeling immediately sick.
So you think that recent uptick in bird cases is not just reflective of enhanced surveillance for detection, or is it a true increase in transmission, do you think?
I personally think that the recent uptick is due to this strain is quite prominent, and it's shifted from Asia. So we would have strains that were just originating in Asia and would stay predominantly there and not really extend out unless there was just this big spread, and then it would die off after a year. This current strain has been prominent since 2020 and hasn't stopped, even on what would be considered not winter season, which would be when they wouldn't expect as many cases. There's been still a lot of cases reported in birds. So at this point, I think it's just too many cases.
There's a question from Virginia Wiseman on the chat. A fantastic presentation. Do you think there's good coordination across modeling networks?
Ooh. I wouldn't say so. A lot of these take time to go across and do 2 different types of models at once. It takes just to even try to do this methodology for all of them would have been impossible because they're just very separate entities. I think SEIRs and agent-based are becoming a bit more coupled, but it's very hard to do phylogenetic analyses and kind of bring that in with agent-based models and SEIR models.
Any more questions? No, if not, I'd like to thank Haley very much. She's done fantastic work in her PhD, and thank everyone for attending.